I have two big goals for my next 20 minutes. First thing, not to put any of you to sleep. As I know, this is the post lunch session and some delicious lunch out there. And the second thing is to at least give you a glimpse of what a chest MRI can do in babies with BPD and how it can help you chat with your families, explain them how this MRI will give you more information on talking to them about what outcomes they'll be looking at in the future. Biggest disclosure I have today is we are all who we are because of our babies that we take care of and the families of these babies. These families, while going through some of the toughest moments of their life, are actually allowing us to, one, not only be a part of their story, but also letting us learn and understand from their personal stories. So I just want to take this moment to thank each and every one of their families and the babies that have helped us become what we are today. Some of the work that I'll be talking about is funded by NIH, and I do not consider myself as an expert in this field. One, I'm not a radiologist. And more importantly, I consider myself as a lucky neonatologist who's passionate caring for these babies with this complex disease, and also lucky to collaborate with the masterminds behind this talk that I'm going to tell you about. Just again, another raise of hands to ensure that you don't fall asleep. How many of you are clinical providers who are at bedside taking care of sick babies? Great, looks like a majority. How many of you are families that are in the NICU have a complete opposite experience of what some of the providers do? How many? How many of you are non-medical in the audience here? We do have some non-medical people, so every now and then I try to use analogies to help with what's going on and what I'm talking to you about. You may have heard about BPD a lot today, or maybe a few times at least. Being a part of this legendary lineup of speakers today, one, it was really intimidating when I first looked at the list of speakers because a lot of them I look up to, learn from them on a day-to-day basis, and inspire on a regular basis as well. However, one thing that I did not realize is my job explaining what BPD is and how complex it is was going to get easier because of some of these speakers. As Dr. Nayland started to talk about this afternoon, so far from what we understand, which was not the case in the 1970s, BPD is complex. There could be several different phenotypes. Some of them could have a predominant parenchymal disease or the alveolar gas exchange level issue. Some of them could have a large airway disease, and some of them could have the vascular component. Or there is some that are even more challenging where there's a significant overlap or predominance of one or another in this aspect. So how do we, on a day-to-day basis, manage this complex disease? For the parenchymal aspect, we get chest x-rays, which comes with some information that's useful to help understand day-to-day management. However, also comes with the side effect of radiation exposure, only 2D projection, and low sensitivity. How about the airway aspect of this disease? The one way our pulmonologists usually do is by using anesthesia, doing your bronchoscopy to tell you whether there is narrowing in the large airways or whether there is significant malacia in these airways. Last but not least, the vascular aspect. We do echocardiograms to understand the cardiac function and how the pulmonary hypertension is in these babies with BPD. However, this is indirect measurement of some of the pulmonary vascular pathophysiology that's going on in our babies with BPD because you're only measuring most of these metrics at the level of right ventricle or pulmonary artery bifurcation. And you're drawing some indirect conclusions from that. Some of the other tools which have better advantages but come with more side effects are your CT, which provides you with great 3D slices, has high sensitivities, however, comes with the challenge of ionizing radiation. And in order to get more information, you may need sedation and breath holding techniques and intubation. Cardiac cath to understand the vascular pathologies also is direct, better assessment, however, is invasive, and there's a need for anesthesia. So, how about if I tell you that without some of these side effects, MRI offers you a potential for phenotyping the disease, quantification of the structural disease, predict outcomes with minimal or no side effects, and also, most importantly, helps you communicate better with your families when you're challenged or faced with some of the most challenging decisions of that family's life in NICU. So our technique is at 1.5 Tesla MRI scanner. It is within the NICU, and it's a 3D UTE MRI, and the resolution you can get down to is about 0.7 millimeters in all three different dimensions. Most importantly, babies are not sedated during the procedure. They're swaddled, fed, no contrast is given. Babies are spontaneously breathing, and there's no change to the respiratory support the babies are on. And the babies do tolerate this procedure well, and we can get all the information that I'm going to share with you within a time of 45 to 60 minutes. So the first aspect I would like to talk about that the MRI provides is the airway component, which is one of the important phenotypes of BPD as a disease. And how we assess the airway in our babies who obtain this MRI is you go through individual axial and coronal slices, 3D reconstruct the airway retrospectively during dynamic breathing images. This, in fact, gives you the beautiful 3D airway that was reconstructed after an MRI during inspiratory phase, as well as expiratory phase that you're seeing in green and red, respectively. And you can reconstruct it into a virtual bronchoscopy. And Dr. Alistair Bates and his group is really pioneering this work, and it gives us information on if there is any narrowing or airway obstruction, what aspect of the airway is obstructed, and how severe the malacia is in these babies. One of our pulmonologists, Dr. Heisinger, who was a part of our BPD team, decided to ask the important question of how does it compare to a real bronchoscopy performed by the pulmonologist? The results were not as exciting as we expected. It was only 0.78, the area under the curve. However, he then looked up the evidence behind inter-rater reliability between two different pulmonologists scoping your same baby. It was not much different. It was 0.78%, 0.8%. So it's about as good as two different pulmonologists scoping a same baby. So you can obtain information on airway malacia, the level of obstruction, and just as a glimpse of how the airway is. Again, the work that I'm sharing today, if y'all watched TV series or movies, I'm just giving you a teaser. Almost every single aspect of this could be a 1-hour talk. So I'm just trying to convince you all, just with the teaser, to watch the movie even more and get convinced yourself. The next aspect is a parenchymal disease. Some of the images from different patients with different types of parenchymal disease. Your cystic, fibrotic, hyperinflated, uh, different types of parenchymal disease. And using the previously developed CT scoring systems, we have applied the same scores to the MRI images and tried to see if this score predicts outcomes in BPD infants. The parenchymal MRI score in infants with different grades of BPD predicted the severity, with mild having the lowest score and most severe having the most highest score. We also looked at whether this score can actually predict what the discharge support is going to be in infants with BPD, and it did a decent job with predicting the discharge respiratory support. Then Dr. Higano and her group said, well, how does just birth weight predict baby support at the time of discharge, which is one of the most important clinical variables we look at. The birth weight was at 0.007, and that is how the trend was when you use just birth weight alone. And when you use gestational age alone, these are some of the numbers that predict it. When you put all these clinical variables as well as MRI score together and try to predict overall need for respiratory support at discharge and the duration of respiratory support, the MRI score did really well when combined with all the other clinical variables added to it. The next most important question the group asked was, okay, it's cool, it's novel, it works well, it's comparing to some of the things that we have already known well. How does this information help us to communicate with our families better on a day-to-day basis? One of the most challenging decisions our babies' families make in the NICU is the timing of tracheostomy, whether the baby needs a tracheostomy or not. So how could we use this MRI score in predicting the need for tracheostomy? And overall, the MRI lung parenchymal score did really well alone in predicting tracheostomy with babies with low score. Not needing trach in comparison to high score means that there's a high likelihood of trach. When you put some of these scores with clinical variables like infection, SGA status, need for antipulmonary hypertensive medications, the score did even better. Cardiovascular assessment, like we talked about, the tools we have are echo and our cardiac cath, though are indirect or can come with side effects like being invasive. With MRI going through, again, axial and coronal slices, we can 3D reconstruct the vascular tree on the 2D time of flight images, as well as you can look at the cardiac parameters that have been shown to predict some of the outcomes which are relevant to pulmonary hypertension. Last but not least, I would like to, when my wife asked me which part of the work that I've been most fascinated about throughout my career at Cincinnati, it's the Xenon MRI imaging. I compare it to the Tesla of chest imaging. So far we've talked about structural aspects of MRI imaging, looking at large airway, looking at the parenchyma in itself, looking at the blood vessels in itself. But Dr. Higano, Dr. Woods have mastered this technique of getting chest images with xenon hyperpolarized MRI gas and assessing function of individual alveoli using this gas. How it works is a patient or a baby in the MRI scan, when given a breath with xenon, which has been proven to be safe, you can obtain images on how exactly this gas is exchanged at the level of individual alveoli. We have some of the first in the world xenon MRI chest imaging, functional imaging obtained in neonates that I've been fortunate to be a part of, which I'll go over in the next couple of slides. The xenon gas is safe and can be visualized on the MRI from an exchange standpoint. How it works is you can also use different frequencies of the same gas at different levels of the airway. The first being the xenon gas in the alveolus after giving the breath, and interstitium, and exchange into the blood cells with different peaks and at different frequencies. And as you can see, the gas initially in the alveoli comes up with one frequency, whereas at the tissue barrier has another frequency, and at the RBC level decays down to a different frequency. This has been well studied in adults. The top half of the screen, you're seeing an adult healthy volunteer. The bottom half of the screen, you're seeing an adult with severe asthma. And on the left half of the screen, you're seeing a control patient on the top with two cystic fibrosis patients with same lung functions. And in all these different images, you can see different levels of dark versus bright areas. The dark areas correspond to the areas where the alveolar gas exchange is not happening completely, whereas the bright areas is where your xenon gas is being exchanged completely. So we used xenon gas, again, first of its kind in the world, in a patient with BPD who was 24 weeks gestation at 41 weeks corrected gestational age, who was on 0.5 liter nasal cannula, and compared some of the UTE MRI images that I talked about previously with xenon imaging. And xenon imaging does pick up more ventilation defects, if not, compared to the UTE MRI imaging. We also plotted the different frequencies at different levels. And even in comparison to the previous graph that I showed you, the RBC peak is much lower, and the barrier peak is not as high as some of the adult imaging that we get. So overall, I always love to apply what I learn on a regular basis. And when Ben was talking about ChatGPT, I just got curious and typed into ChatGPT on what it thought about xenon MRI, as this was a technique that was built before 2019. And at least ChatGPT seems to think that it's a promising technique. It's an innovative technique, and it would add value to the clinical care. So with those three things, I've convinced, at least I think the group has convinced ChatGPT to meet all the goals and objectives I started with. But with some of these slides and some of these stories, I hope I was able to give you all a glimpse of what kind of work that's being done at Cincinnati. And I want to thank again the Delphi group for having me here share some of the work. So.